empty vaccination sites. But it's not on the community. It is our collective failing, in most cases, the government, who has the mandate and the resources to do the meaningful community engagement and to fund those of us who do that, to take up that leadership role. But I think the tension you talk about is also fueled by a failing in our communications efforts that push these COVID-19 vaccination plans, almost positioning them as punitive measures or tools of punishment. Why are we not investing in the hard work of engagement? That's a question which we constantly strive to answer. But it's also a question of how do we get communities to fall in love again with the health system? It's quite difficult. But in any health context, you would want communities to willingly and knowledgeably uptake a service. If they are resistant to that, then the hard questions must be asked about who takes ownership of our current situation. So where have we failed in ensuring that health systems across this continent meet communities in all of their diversity at our point of need? Why did we think it was going to be different with COVID when it came to issues of prejudice, of bias, of stigma, of how Africans who sell sex experience healthcare, around queer Africans like myself experience healthcare? Why did we think COVID was going to be any different in terms of our HR needs, in terms of capacity building needs, in terms of skills building, dealing with prejudice and bias? The fact that we still have inadequately served populations today in 2021 in our joint health response tells us everything we need to know. The fact that we continue to sideline those in detention, those who sell sex, those who identify as LGBTQI, the fact that those groups still remain underserved is an indictment on us collectively throughout the disease areas that we've worked on for years. So finally, I'd just like to say that our response has to embrace all of the communities. And while mandates might have a place in contexts, the real work has to happen with communities. And that work has to happen with integrity and trust. And that does not mean an infographic posted on Twitter. That does not mean a piece in your weekly national newspaper. That does not mean a selfie at the airport with a consignment of vaccines. That means groundwork, the hard door-to-door work, where we derived our success from HIV and TB in years gone by. Thank you.
Well, thank you very much for that, Tian. That's really, provocative. As I said, sent my head, spinning. The problem is us and not being willing to do the hard work that must go into community engagement. But Tian, just to ask you, how do you prep for community engagement in pandemics where you sometimes cannot tell what's around the next corner? In a pandemic where you're learning as you're going, and people have accused governments and scientists of flip-flopping. Today it's this, oh no, tomorrow, oh, it's actually that. And they don't understand why the science has to lead, and we're learning as we're going. So as the knowledge accumulates, we may go back on certain things, or we may provide more clarity on others. And people are not comfortable with this. They want it to be clear. A, B, C, or D, what do we do? So how do you prep for community engagement when you don't even know the full extent of the problem? Can you just, tell us how to get this hard work? It's hard enough even when you know, and how much more when you really don't know.
Absolutely. I think one way of prepping is listening to what civil society has been saying for nearly 2 decades. We've been calling for an appetite of humility within the research and scientific community. There has to be. We have to approach this with humility. And I guess we've become our own worst enemies by positioning scientists and researchers and virologists as these kind of rock stars, right? And of course, history has shown us that scientists and researchers, with all respect to them, are sometimes not the best communicators. Sometimes they are the worst communicators I've ever seen, and further push communities into confusion and doubt. So we've always called for a sense of humility in engagement, a recognition and an acknowledgement that science is changing. What we know today might not be what we know tomorrow. And so I think by practicing that basic concept of humility, which we don't currently see, in the science and academia spaces. That would be a really key way to allowing communities to understand that this is a journey we are going on together. There will be mistakes, there will be errors, but we will try at the very least. Our point of departure has to be accountability and transparency. The fact that we don't have sites of vaccine contracts, the fact that we don't have sites of protocols, huge COVID-19 vaccine protocols, the fact that those are kept hidden is a huge problem. We need transparency and accountability. And the scientists and researchers that lead this work hopefully have now learned a hard lesson that going into the next pandemic, we don't do research for research's sake, but we do research to ensure that there's going to be eventual access. I'd love to hear what the scientists who have worked on COVID-19 vaccines, specifically in Africa, are now saying about all of the work, effort, millions of dollars, and African bodies who made that research possible. Now, as we look on to our colleagues in the global north, getting their third booster shots and vaccinating their animals in their zoos.
Well, thanks for that, Tian. I just want to press yet some more. You talked about the need for scientists to be humble, and I totally support this. But it's also a bit of a paradox because people like, in Africa, I should say, we like strong leaders, people who inspire confidence, who can say, this is it, do this, and it shall be well with you, my people. but people don't like, oh, baby, and, you get what I mean. So how do you balance this humility with yet being able to be confident? And this is where, I guess, this is where Donald Trump also went to the other end, where he said, look, you don't have to show weakness, you got to inspire confidence. Through lying to the people, so to speak, just paraphrase. All right.
Yeah, no, absolutely. I get the whole concept of strongman leadership, and that'll just take us into a whole different session around patriarchy and power and masculinities on the African continent. But I'll respect the fact that this is not that session.
I was just trying to tempt you.
As you were speaking, a crystal clear example came to my mind. At the outset of this pandemic, you had one of Africa's best scientists, Slim Abdul Karim. He came on our television screen that he was about to present. It was the early days, spectacular confusion. Even us who were in the space had no idea what was happening from day to day. And we were just tired of seeing these endless graphs and PowerPoints and mathematical models and talk of variance. It was overwhelming. Slim Abdul Karim came onto national television, primetime, 7 p.m. news, and he put up a slide. And this slide had images of trees, it was a forest with very small fires. And in that one slide, because we do a lot of work monitoring social media and sentiment on social media, and based on different scientific presentations, you can see levels of interaction. And that slide was one of the most interacted with slides in the pandemic to date. The fact that he took the opportunity to explain in a simple but not condescending or patronizing way the potential of us having to stop this pandemic or contain the pandemic at that stage through a simple message of communications and using the analogy of small fires that we've seen now raised with the new Omicron variant. You're seeing a lot of social media content using that analogy of we can't have one room in the house on fire and think that that's okay. And so I think it's that combination of practicing the humility. So it's not just humility for humility's sake, it's thinking about your slides, it's thinking about the messages you are putting out. How do you proactively engage community organizations? In this country, the Medical Research Council has engaged the African Alliance, for example, from the outset of the pandemic. And so we hold them to account as a Medical Research Council to ensure that every single thing they do, every statement that they put out, any new developments, we watch, we monitor, and we guide. So that's the humility I'm trying to get across, is take your leadership from communities in terms of how you communicate.
No, thanks, Ken. I think you used a really beautiful example of Salim, who I also happen to know, a really, really amazing leader. And I think I'm glad you could bring that home so powerfully with that example. Thank you so much. But we're going to move on, and I just want to engage all the panelists in a quick discussion on a couple of issues. First one is the role of communities in engaging in passive and active disease surveillance. Not only during pandemics, but just disease surveillance in general. Because ultimately, to surveil, you need to have eyes on the ground, and you cannot have eyes on the ground without the permission or the engagement of the community. Also, not only their role in active and passive surveillance, but also in prevention, simple things like water, sanitation, and hygiene, which are the bedrock of infection prevention. But how can we engage the community in a direct and deliberate way connected to health systems strengthening in active and passive surveillance? I'm just going to come to you, Philana, if you could just address this.
Sure, thank you. And thanks to the other presenters for the excellent presentations. Now, as I mentioned, blood is essential for the treatment of several diseases, but also to prevent deaths directly. And it's critical to engage communities around donating blood because there is no substitute for blood. And at the Coalition of Blood for Africa, what we're very, very proud of is we actually have a partner, the Global Blood Fund. And this is an organization that has decades of experience helping blood centers, ministries of health, local communities develop blood drives that actually motivate communities to come out and donate. They tailor programs to deal with different things like hesitancy, taboos around blood donation, but they also give guidance on basic things like thanking the donor, making the blood donation process a pleasant one that you'd want to do again. All too often, it's not a very pleasant experience, unfortunately, even though that community member is doing something incredibly powerful and incredibly selfless. So I think what we can apply to even other areas of surveillance or prevention is trying to develop strategies that actually look at what the motivators are to drive communities to actually do the preferred action. And in this case, if it's something around a taboo to do with blood, what sort of strategies can you employ that will alleviate that taboo in that particular community? And the other thing that we've seen from a lot of the Global Blood Fund's work is this needs to be a sustained effort. It cannot be a one-touch thing where you just do one blood drive and you forget about it. You need to keep getting the same community member to keep doing the same thing again and again. And that's the only way you're going to ensure sustainability. And that's the only way that you're going to be able to actively and consistently alleviate diseases and also ensure that that community is mobilized to prevent and surveil for disease. So I think what I can say is check out the work of the Global Blood Fund. Of course, they focus on blood, but a lot of their strategies could be applied to other health system strengthening initiatives.
Thanks, Philana. Don't go yet. Just a quick one. I'm sure you should have many examples, but can you give me one exciting example of how, through your work, you managed to engage communities to change perceptions regarding certain taboos, which were impinging on your bloody work?
Yes. Well, this was actually a very exciting campaign that Terumo BCT run with the Global Blood Fund right at the height of the pandemic. And it was a project we run in Ghana. And we realized that particularly in rural communities, there was very low blood donation. And what we did is we identified queen mothers as being very influential community leaders in their kingdoms. And so with the Global Blood Fund and working with Ogilvy, who are an international PR and advertising firm, and the Ghana National Blood Service, and the First Lady of Ghana, we developed a program to train the queen mothers around why blood donation was so important and the value of blood donation for their communities. And we actually helped the queen mothers design programs and initiatives to mobilize their communities to donate blood. And this was a very successful initiative because the Ghana Blood Service reported that they saw a huge increase in the donations in rural areas where these queen mothers had now turned into blood advocates and blood activists. And it was a very simple, modest program, but what we were able to do was to tailor the training for the champions to elderly women and explain the importance in a way that made sense to them and that they were able to relate to their communities. So that's an initiative that I think we're very proud of.
No, many thanks for that, Philana. It really comes home for me because I'm based here in Ghana. But coming to you, Bright, still on the same question around community engagement in passive and active disease surveillance and linking that very deliberately to health system strengthening. What are your thoughts on this, especially given the space within which you work in technology?
So when we first started rolling out our solution in the different countries, we thought the line between us and our primary audience was an uncomplicated one. Primarily wanted patients to be aware that we walk into a pharmacy, you can now check, and if you have issues, just report back. We discovered that in a few months, the pharmacists had a problem because some of the behavior that was being exhibited by the patients now was one of low trust. Because somebody walks in, normally they give them medicine, the person asks them questions, they have this trust bonding relationship that they've been cultivating for many years. And then you bring in this technology and introduce this intervention that begins to disrupt this trust, because all of a sudden you are telling the patient not to rely on the pharmacist for this kind of very essential feedback, but to rely on some external system. So we discovered